Welcome to Module 3 of the Limb Loss Rehabilitation Specialist Certification. And so now we will talk about anatomy. And instead of giving you a PowerPoint, I think it was more important to take a look at the anatomy from the view of an app. And so we'll talk about anatomy and some considerations, different levels of amputations, and some key considerations that you may want to think about when you're working with an individual with limb loss with a respective level of amputation. Some things that we will talk about in detail, some we will say for the in-person course, but I think it's important for us to kind of start thinking about how the anatomy and the level of amputation will ultimately affect that person's quality of life and what you can do from a rehabilitation standpoint to ultimately improve that quality of life. So the amputation level is not just a surgical decision, it is the single most important variable in your patient's rehabilitation ceiling. And most rehab clinicians are not taught to think about it that way. Every joint preserved, every centimeter of residual limb length, every muscle attachment maintained or lost determines the metabolic cost of walking, the prosthetic options that are available, the deformity risk, and the trajectory of your patient's functional independence. So think about it this way. If the human body were a lever system, amputation level determines the length of your lever arm. A longer lever arm means more mechanical advantage, less compensatory effort, and lower energy costs in a patient who is more likely to walk out of your clinic and keep walking. You shorten that lever arm, move the amputation level more proximally, and you're not just taking away a bone, you are removing the muscle attachment, proprioceptive input, end-bearing surface, and rotational control, and ultimately the function. So we'll cover most of the levels from partial foot all the way through the pelvis of the lower extremity, and then from the fingers up to four-quarter amputation on the upper extremity. For each level, we'll discuss which anatomy remains, when it's lost, the biomechanical consequences, energy costs of ambulation or function, some general rehabilitation and prosthetic considerations that follow, and some clinical pitfalls your patient may be walking into, whether or not they have a therapist who knows about them or not. So we'll start with the lower extremity first. We'll start off with toe amputation. And toe amputations are the most common lower extremity amputation in the diabetic population. They look simple, but they are not. If you look at the consequences of having a toe amputation, and in the literature, we know most times that once a person has a toe amputation, it usually means that down the road, there's the high likelihood of a more proximal amputation, whether it be a transmetatarsal, a SIMS, or ultimately a transtibial, or even higher. And so the hallux or the great toe is the primary lever for terminal stance push off. It is where your patient concentrates forces at one end of every step. When it is gone, that propulsive mechanism is disrupted, and your patient will ultimately compensate by loading the lateral forefoot differently, by altering their cadence, and eventually by offloading to the sound limb in ways that accumulate over years and years and years. A ray amputation or removal of the toe with its associated metatarsal creates a narrow forefoot and alters the pressure distribution across the transverse arch. More forefoot area removed means more low concentration of what remains. And clinically, the question you're always asking with a partial foot amputation is, what is the wound healing environment? The vascular supply drives everything at this level. A traumatic ray amputation in a 28-year-old heals differently than a diabetic toe amputation in a 68-year-old with peripheral artery disease. Now, toe and ray amputations are rarely ever the end of a story in a dysvascular patient. Your job at this point is to optimize function while watching the trajectory, because we are ultimately trying to prevent a more proximal amputation over time. So it's going to be very important that we're always checking our patients' feet, that we're giving them the tools to be able to do so, and we're also working with an interdisciplinary team to make sure that they're getting everything that they need in order to remain healthy and to prevent further amputation of more proximal limbs. So some prosthetics that you may see at this time would be toe fillers, custom insoles, specialty diabetic footwear. The goal here is pressure redistribution, not restoration of anatomy. And as far as some rehab goals, we'll be looking at gait retraining, balance, intrinsic foot strengthening of remaining musculature, and footwear education. And most importantly, in my opinion, would be skin inspection. Now we'll move on to transmetatarsal amputation. Transmetatarsal amputation removes all five toes and the distal portion of the metatarsals. The foot retains the hindfoot and midfoot architecture by the calcaneus, the talus, the navicular, the cuboid, and the cuneiforms are all still present. This is a functionally valuable level. The patient retains substantial plantar weight bearing surface, hindfoot biomechanics, and most importantly, the Achilles tendon mechanism is entirely intact. They can walk, they can transfer, and many can return to meaningful community ambulation. However, there is a biomechanical vulnerability at this level that is easy to miss: the loss of the forefoot lever arm. And in normal gait, the metatarsal heads acts as the pivot point for terminal stance. You remove them, and your patient is trying to push off of a foot that no longer has that pivot. They will recruit ankle plantar flexor earlier, alter their step length, and develop asymmetric loading patterns. And so we see now, we're looking from a sagittal view, a patient with a transmetatarsal amputation. They do no longer have that forefoot lever arm. And if we're looking at our rockers and we're using the four rockers, we no longer have the forefoot rocker or the toe rocker. And so now, what does that do for our biomechanics in terms of gait? Well, most likely, we don't have a prosthetic to fill this space. That's going to ultimately shift our lever arm. The patient is ultimately going to have a shorter step length. If they have a shorter step length, if we look at what is going on at the hip, that means that they're not ultimately going to be using the full range of motion that they have at the hip. And over time, what does that do for the hip range of motion over time? That joint capsule ultimately will probably close, and the joint mechanics at the hip will ultimately be affected as well. So there are a lot of downstream effects with a partial amputation. And so if a person does not have a partial foot, a carbon fiber toe filler prosthesis, or an ankle foot orthosis with a custom toe filler, then we have to do everything we can to make sure that we maintain the range of motion at all the joints above, because ultimately with the walking mechanics that will be available to this person, they ultimately will start to lose range of motion in the more proximal joints. So reamputation rates at transmetatarsal amputations are notable. One systematic analysis showed crude reamputation risk around 40% at transmetatarsal levels in vascular patients, the highest of any level study. Wound healing failure is the primary driver. A transmetatarsal amputation that fails to heal becomes a transtibial amputation. You optimize the wound environment aggressively from day one. And so some common prosthetics that you may see would be a carbon fiber toe filler, ankle foot orthosis with a toe filler, custom footwear, and the goal at this point is to restore the forefoot lever arm. Our rehab focuses again will be wound care, edema management, gait training with assistive device initially. Then we'll have progressive weight bearing and balance. The Leus Franck amputation is performed through the tarso-metatarsal joint, and it removes all the metatarsals and toes while preserving the entire hindfoot and midfoot. Functionally, the Lisfranc level offers better ambulatory potential than is often assumed. Studies show that approximately 85% of Lisfranc amputees can walk short distances without a prosthesis. With appropriate prosthetic fitting and rehabilitation, functional community ambulation is achievable. Now, the critical complication risk at this level is the subsequent equinus deformity. With the dorsiflexors severed at the tarsometatarsal joint and the Achilles triceps group unopposed, the hind foot is now pulled into plantar flexion. Now, if this is not addressed surgically through tendon lengthening, balancing procedures, or tenodesis, it creates a plantar pressure concentration of the residual limb, stump, and that is a wound care nightmare. So some things you should make sure you're looking at in the surgical note, finding out if tendon balancing was performed, and unbalanced Liz Frank amputation is a future wound in waiting. So some prosthetics that you may see would be articulated ankle foot prosthesis with a clamshell design, or some custom footwear with prosthetic filler depending on the residual length. Rehab focus, our primary focus would be equine prevention and management, gait training, of course, always skin inspection, and progressive loading. Now, if we were to remove the navicular, give me a second here, and we'll see that the Chopard amputation is through the mid-tarsal joint, leaving only the calcaneus and the talus, as you can see here in the picture here. And it is a more aggressive resection than the Liz Frank, and the biomechanical consequences are correspondingly more significant. Wound healing failure rates are substantially higher in the Chopard compared to the Liz Frank, upward of 46% in some systematic reviews for conventional Chopard, and with modified techniques showing somewhat better results. The calcaneus is a challenging residual limb to cover and protect. The equinus deformity risk is severe at this level. The fibularis brevis, which is one of the primary everters, and the tibialis anterior, a primary dorsiflexor, are both lost with this amputation. What remains is the unopposed pull of the plantar flexor group through the Achilles complex. Without surgical balancing, these patients will develop a rigid plantar flexion contracture. Now, there is some ongoing debate in the literature whether about Chopard or Symes amputation procedures produces better long-term function. Evidence at this time does not clearly favor either, and the patient level factors, vascular status, healing capacity, and contralateral limb condition, cognitive status matter more than the level alone. So some prosthetics that you may see at this time would be custom molded prosthesis or ankle foot orthosis. Fitting is technically pretty challenging at this level. So our focus for rehab would be contracture prevention, skin management, progressive ambulation, and assistive device training. Now, as we move on, we can go into the Symes amputation. And the Symes amputation is also called a ankle disarticulation. And we can see here, if I were to take a pen and draw it through, and also kind of in here, we're kind of basically going straight through the ankle joint. And it basically removes the entire foot, including the calcaneus and the talus. So if we take this here and we remove the calcaneus and the talus, we're ultimately left with the tibia and the fibula. And it removes the entire foot, including the calcaneus and the talus, while preserving the calcaneal fat pad, which we aren't able to show in this anatomy app here. but the malleoli are resected flush with the tibial plafond, and the heel pad is secured over the distal tibia to create a durable in-bearing residual limb. Now, this is biomechanically one of the most favorable amputation levels that exist, and here's why. Besides cosmetic looks, the residual limb is in bearing. The patient can bear weight through the distal end, which means transfers, short distance ambulation without a prosthesis, and toilet safety are realistic at this point. The Achilles mechanism is gone, but the heel pad preserves in limb proprioception and a durable weight bearing surface. Some will argue that the gait stability is superior compared to transtibial amputation. Energy expenditure is lower. Walker cadence and speed are closer to normal. Some people who are in rehab will say that patients require less gait training than transtibial amputees at this point, but again, there is some debate about that. Energy expenditure data supports SIMES as the most efficient foot amputation level. Studies show that SIMES amputations expend the least walking energy of any level above partial foot, followed by transtibial and then ultimately transfemoral. Now, some key points is that if your patient has a viable heel pad, a SIMES amputation is a considered a gift. So treating it that way, the prosthetic challenges at this point is real, but the functional ceiling is high. There are some things we will talk about in more detail in-person course in terms of whether people consider or prefer to do a SIMES amputation over a transtibial, whether it's done in the pediatric population, but we'll save that conversation for the in-person content. The prosthetic challenge at the SIMES level is the bulbous distal end. The calcaneal fat pad creates a wide distal residual limb, and that makes prosthetic fitting cosmetically awkward and requires specialized socket designs, typically a window posterior panel that allows donning over the bulbous end. So you may see a SIMES prosthesis with posterior panel and bladder design. A low prosthetic foot is typically required because now you don't have as much space. If we're looking from this level here, you don't really have enough space for one of those more complex designs in terms of prosthetic feet. The ability to use things like rotators and shock absorbers, that possibility is going to be reduced because of the low build height that you will have in terms of fitting a patient with a SIMES amputation. Our rehab focus with that ability to do distal end weight bearing, we're going to look for early mobilization, prosthetic training, gait normalization, and strengthening of the ankle musculature. Now, the transtibial amputation is the most common lower extremity amputation level there is. In the veteran population study by Bates and colleagues, transtibial accounted for nearly 60% of all lower limb amputations. For your practice, this is probably the level that you will see most frequently. What is preserved at the transtibial level that makes it clinically valuable? The knee joint is entirely intact. This is not a small thing. The knee is the single most important joint for energy efficient gait. Every joule of metabolic energy expended during walking that goes through a functioning knee is more efficient than anything a prosthetic knee can do. The quadriceps, the hamstrings, the gastrocs origin, they're all intact. You have a complete muscle group to work with at the knee. Strength and control at the proximal segment are preserved, and proprioceptive input from the knee is intact. Now, what is lost? The ankle joint and its plantar flexor dorsiflexor function is entirely gone. The intrinsic foot architecture is gone as well, and ground reactive proprioception from the plantar surface is significantly diminished. Now, some things that most people don't consider is that when the in the transtibial amputee, we focus on a lot of flexion and extension, but there has been a decreased amount of focus on restoring tibial rotation. And if you remember from basic biomechanics, that the tibia will ultimately externally rotate to lock. And if we restore internal and external rotation of the tibia, that will a lot of times decrease a lot of edema within the joint and allows full function at the knee. So the hard part of restoring the internal and external rotation is that we lose that lever arm of the foot to give us a biomechanical advantage in terms of trying to create the torque at the knee joint. But through some soft tissue compression and with gripping the tibia and the fibula with a firm grip, you are able to promote internal and external rotation at the tibia. Now, the energy cost of transtibial ambulation is well documented. Non-vascular transtibial amputees expend approximately 10 to 40% more metabolic energy to walk at the same speed as able-bodied peers. Individuals with amputations due to vascular reasons who are typically older, deconditioned, and have systemic disease expend substantially more. This is not just about the ankle. Stabilizing walking after transtibial amputation creates its own energetic cost independent of propulsion. Now, residual limb length matters at the transtibial level. Longer is generally better. The longer lever arm, the more muscle for prosthetic control, better suspension, but not infinitely longer. The distal third of the tibia has poor soft tissue coverage and high wound healing risk. So they would say in the literature and recommendations most times that the sweet spot is roughly 12 to 15 centimeters distal to the tibial plateau. Surgical technique will matter for the rehab outcomes. A posterior myoplasty or myodesis that anchors the gastroc flap anteriorly creates a padded, durable distal residual limb. If the surgeon has done this well, you have a tissue-tolerant distal end that will withstand prosthetic loading. If not, the residual limb has a bony distal prominence and thin soft tissue coverage or a poorly padded anterior tibial crest. Your prosthetic options are constrained and your wound care burden is slightly higher. So for prosthetics, you'll see varying designs, but some very basic will be patellar tendon bearing, total surface bearing sockets, or image during prosthetic foot. You'll see things like pin systems or elevated vacuum, suction as well. And then for our rehab focus, we want to focus on residual limb shaping, desensitization, and weight bearing progression early. Also strengthening of our hip extensors, restoring that tibial rotation, which in byproduct should help restore flexion and extension. And then also looking at our hip abductors and prosthetic gait training and fall prevention, in which we will talk about these in more detail during the in-person course. Now, moving more proximally, we'll go and look at the knee disarticulation amputation. And the knee disarticulation is an amputation through the knee joint itself. The femur is fully preserved, both condyles are present, and all thigh musculature remains attached. This is a level with an almost paradoxical reputation. Biomechanically, it is superior to transfemoral amputation on nearly most of the metrics that matters, but it remains underutilized in part because of the prosthetic challenges and the cosmetic concerns. Now, what makes a knee disarticulation functionally advantageous, all thigh musculature remains attached. The quadriceps, hamstrings, and adductor group are intact. You have full motor control and a complete lever arm. The femoral condyles provide an end-bearing surface. Without a prosthesis, the patient can bear weight through the distal residual limb and an enormous functional asset for transfers and toilet safety. Socket designs usually is subischal, meaning less pressure on the ischial tuberosity with generally better comfort, better prosthetic control due to the long lever arm and intact muscle attachments. Now, a survey of 102 prosthetists showed exactly this distinction. 53% preferred knee disarticulation over transfemoral, citing distal end bearing, lower socket, and better function. 47% preferred transfemoral, primarily because of the prosthetic component options and the cosmesis. Unfortunately, at this time, there is no consensus on which is better. The evidence does not show functional score differences between knee disarticulation and transfemoral amputation at long-term follow-up. In absence of a proven functional difference, most surgeons would typically choose to amputate at the most distal level that the tissue allows. The primary prosthetic challenge at knee disarticulation is the bulbous femoral condyle region, similar to SIMS at the ankle. Conventional prosthetic knee mechanisms can't be mounted in the normal anatomical position without creating a limb length discrepancy. Specialized polycentric four-bar knee systems designed for through the knee amputations address this but add some complexity. So our rehab focus at this time for this level, just some general considerations would be hip strengthening, gait training, balance, fall prevention, and full quadriceps and hamstring strength is available. So it'll be in our best interest to use it. We also want to make sure that we are starting the residual limb loading as early as possible that the healing allows. Now, we've already done the transtibial and the knee disarticulation, and now we'll move up to what we will call the transfemoral or the above knee amputation. And so we'll just draw a line here to kind of delineate where that amputation may occur. Again, it can occur at any point on the spectrum above the femoral condyles, and all of these will be considered a transfemoral amputation. Now, the transfemoral amputation is where the rehabilitation complexity increases. We have lost the knee joint, and everything that follows in the gait cycle has to be reconstructed with a mechanical substitute that cannot, at any price point, fully replace what was biologically provided. We understanding what is lost. We lost the knee joint and all intrinsic knee mechanisms. The gastroc origin, patella tendon mechanism, they're all gone as well. Distal attachments of the adductor group partially or fully disrupted. Then that last point deserves special attention. The work of Gottschalk and colleagues on transfemoral biomechanics established something every rehabilitation clinician needs to understand. The adductor magnus is the primary stabilizer of the femoral shaft, and its anatomical axis is mentioned, often noted that the adductor magnus attributes to 70% of adduction strength. Its distal attachment is the adductor tubercle of the medial femoral condyle. When you amputate through the femur, you sever that attachment, and without surgical correction, the unopposed pull of the hip abductors drives the residual limb femur into this flexion and abduction posture, which leaves the patient with a likelihood of having a flexion, abduction, and external rotation contracture. This is the triad and is not a contracture problem. It is more of a muscle imbalance problem created at the moment of surgery. And a flex and abducted femur means a prosthetic socket that cannot be aligned properly, which causes compensatory gait deviations and increased energy expenditure. Now, a key point I want to mention is that in adductor myodesis, which is surgical anchoring of the adductor magnus to the distal femur through cortical drill holes, is an intervention that prevents this. I think it's important that if we have that interprofessional collaboration, that we're talking to the surgeons to find out if an adductor magnus myodesis was performed or is being considered for this level of amputation. Residual limb length has a direct relationship with walking speed at the transfemoral level. Patients with longer residual limbs self-select faster walking speeds. The lever arm physics are straightforward. More femur means more control, more surface area and area for socket suspension, and more muscle for muscle force transmission. Some general guidelines you will see is that the residual limb length should be approximately 50 to 60% of the contralateral femur. Too short creates an inadequate lever arm. Too long, extending into the distal third of the femur, reduces space for prosthetic knee components and creates limb length discrepancy challenges. Some energy expenditure at the transfemoral level is significantly elevated. Unilateral transfemoral amputees walking with a prosthesis expend approximately 50 to 70% more energy than able-bodied peers, and many approach 90 to 120% of VO2 max during prosthetic gait, particularly in the older and dysvascular patients. There are many different styles of prosthetics that you will see, and our rehab focus is going to be restoring the internal and external rotation of the hip, and also hip extension and abductor strengthening, prosthetic knee control training, fall prevention, cardiovascular conditioning, because the metabolic demand is so enormous. We want to make sure that we're watching for early hip flexion, abduction, contracture, always monitoring residual limb volume fluctuation and socket fit issues early. The hip disarticulation removes the entire lower extremity at the hip joint. Now the femur is gone. Every muscle that is attached to the femur, the quadriceps, the hamstrings, the adductors, the tensor fasciae lata, the IT band, is either resected or loses its distal anchor. What remains is the pelvis is still intact. The gluteal musculature, it no longer has a distal attachment, but it is still present. The lumbar spine, sacrum, and contralateral limb are largely unchanged. Hip disarticulation and hemipelvectomy together represent less than 1% of all lower extremity amputations. They are most commonly performed for malignancy, severe trauma, or life-threatening infection. The rehabilitation challenge at this level is substantial and the literature is limited. Most published series have small sample sizes. Energy expenditure data at the hip disarticulation level is pretty striking. Studies show walking energy cost at approximately 82% above normal bipedal gait when using a prosthesis. Walking speed is reduced to approximately 72% of normal. Heart rate is significantly elevated throughout ambulation. This is not a population that can walk across a parking lot without physiologic consequence. Less than 50% of people with hip disarticulation use a prosthesis in everyday life. This is not considered a failure. This is a rational response to the metabolic cost of walking. A wheelchair is not giving up. It is sometimes the most functional choice for this population. For patients who do pursue prosthetic ambulation, the hemipelvic socket must capture the ischium, create suspension, and transmit force through a system that has no femur to anchor to. Modern polycentric hydraulic hip joints have improved gait biomechanics at this level, but the fundamental physics remain pretty challenging. Our rehab focus with this population, and we'll look at core and trunk strengthening, gluteal activation, cardiovascular conditioning, activities of daily living training, and prosthetic training if preferred. Wheelchair mobility training should run parallel and not as a backup, but as a primary strategy. We want to make sure, if you can see, that we have the remaining musculature of the spine, and so we want to ensure that all levels of the spine are able to articulate and segment individually, largely, and we'll talk about when we get into the in-person course, where most times we look at the spine as one continuous unit, but we can see that each individual vertebrae has a corresponding joint where it articulates with another vertebrae. So if we improve spinal segmentation, it will ultimately allow us to take some of the forces off of the other parts of the anatomy. And moving along, we went through the hip disarticulation, and now we'll speak on the hemipelvectomy. And so the hemipelvectomy is the most proximal lower extremity amputation level. External hemipelvectomy removes the hemipelvis, ischium, ilium, and pubic ramus on one side, along with the entire lower extremity. Internal hemipelvectomy preserves some of the pelvic bone while removing the limb. What this means functionally, the patient no longer has an ischial tuberosity on the involved side for weight bearing and sitting. The gluteal muscle mass is significantly reduced. Spinal support and pelvic symmetry are altered. Prosthetic use rates at hemipelvectomy are similar to or lower than hip disarticulation. The prosthetic socket must reconstruct a supporting interface from the remaining hemipelvis, sacrum, and the lumbar spine, a surface that varies substantially between patients based on surgical technique and the remaining anatomy. Functionally, the hemipelvectomy amputee becomes accomplished wheelchair users with proper seating, positioning, and upper extremity conditioning. Meaningful independence and community participation are achievable without prosthetic ambulation. At this level, the rehabilitation goal is not always ambulation, it is a functional independence, community participation, and quality of life by whatever means the patient can achieve it. Again, we want to focus on seating and positioning, trunk strengthening, upper extremity conditioning for wheelchair propulsion, activities of daily living, and transfers with this population. Now we want to move on to the upper extremity, and the upper extremity population looks different from the lower extremity population. Whereas lower extremity amputations are dominated by vascular disease and diabetes, upper extremity amputations skew towards trauma, malignancy, and congenital limb difference. The goals are different too. Instead of ambulation, we are primarily targeting upper limb function, reach, grasp, fine motor control, and bimanual tasks. One number that should anchor every upper extremity rehabilitation decision: prosthetic rejection rates range from 30 to 80%. That is not a technology failure, it is a mismatch between what the device can do and what the patient needs it to do, often because rehabilitation started too late, expectations were not set, or the device was not fitted to the patient's actual functional demands. The data on timing is stark. Fitting within 30 days of amputation produces a 93% rehabilitation success rate and 100% return to work within 4 months. Beyond 30 days, success rate drops to 42% and return to work rate drops to 15%. This window matters. Early fitting and early rehabilitation are not just best practice, they are the difference between a prosthetic user and a prosthetic rejection. Now, this is not to say that every upper extremity amputee would like to use an prosthesis. However, we want to make sure that we're putting them in a position to where they are successful if they choose to use one. Digit or partial hand amputations fall into minor amputation classification below the wrist. They include phalangeal amputations, partial digit amputations, and ray amputations, removing the digit and its associated metacarpal. The hand is neurologically the richest peripheral structure in the body. The cortical mapping of the hand is disproportionate to its size. What you lose with a digit amputation is not just bone and tendon, you lose sensory discriminative capacity, proprioceptive feedback, grip surface area, and in case of the thumb, oppositional pinch. Thumb amputations deserve special mention. The thumb alone accounts for approximately 40 to 50% of hand function. Restoration of any opposition through prosthetics, tendon transfers, or toe to thumb microsurgery is a high priority reconstructive goal. Some prosthetics that you may see: passive silicone digit prostheses, partial hand prostheses. These improve cosmesis but rarely restore the full sensory function. Rehab focus will look at desensitization of the residual digits, gripping, pattern retraining, and adaptive techniques, and vocational rehabilitation. As for the wrist disarticulation, it removes the hand at the radiocarpal joint, as we can see here, while preserving the distal radius, ulna, and critically the distal radial ulnar joint. Why does that matter? Because the distal radial ulnar joint is what allows forearm pronation and supination. Preserving it means preserving the ability for the residual limb to rotate, but what can be transmitted into a prosthetic device. Up to 50% of forearm rotation can be transmitted through a prosthetic wrist unit at this level. The longer residual limb also means better suspension, control of any prosthetic device, and the styloid process serves as a natural suspension points. The prosthetic limitation at the wrist disarticulation is space. A conventional prosthetic wrist unit or terminal device requires length. A wrist disarticulation residual limb is long, fitting. A standard prosthetic system may create a limb length discrepancy of the prosthetic side relative to the contralateral limb. Some prosthetics we may see low profile wrist units. We can use body power or myoelectric terminal device. Limb lift management requires specialized components. Our rehab focus is going to be full range of motion and maintenance, forearm rotation for prosthetic control, and terminal device training as well. Just like in the lower extremity, we want to always work on some type of residual limb loading strategies, just to make sure that, again, we want to make sure people are more functional and they can do things to at least bear some weight through that wrist if they so need to. Now, we're going to look at transradial amputations, which is anywhere between any of these points here. It's going to be below the elbow. So our transradial amputations are going to be below the elbow here. And with a transradial amputation is the most common major upper extremity amputation level. It is the level with the highest functional ceiling and some would argue, the best prosthetic outcomes in the upper extremity population. Length is everything at this level, and here's why. A long transradial amputation with approximately 55 to 90% of the ulnar length allows up to 60 degrees of supination and pronation with a prosthesis fitted and maintain strong elbow flexion. A medium transradial amputation, 35 to 55%. Pronation and supination through a prosthesis is largely lost. Elbow flexion is maintained but partially inhibited by the socket. A short transradial amputation between 0 and 35% of the ulnar length. There's difficulty in prosthetic suspension. There's loss of full elbow range of motion, and there's significantly reduced control options. Think of the forearm like a volume control knob on prosthetic function. The longer the residual limb, the more control you can extract from it, not just mechanically, but also through myoelectric signal quality. Longer muscle bellies closer to the electrodes produce cleaner, more differentiated EMG signals. And we'll talk about that in more detail when we discuss upper extremity rehabilitation principles in the in-person seminar. Elbow range of motion is a prosthetic prerequisite at the transradial level. Full active elbow flexion and extension allows the patient to position their terminal device in space. If the elbow tightens, everything above it becomes a compensatory mechanism. Myoelectric control at this level is typically achieved through two-site control, flexor carpi radialis and extensor carpi radialis, or whatever muscle mass remains, serve as the controlling electrodes for hand open and close. Early myoelectric site testing and training, ideally beginning in the acute phase, builds electrode control before the patient even has a device. So this is another instance where we could easily implement biofeedback or EMG activity, or just simple isometric training early on in the rehabilitation process. If we can get those muscles to contract early, we can find out what that does, and ultimately it improves the functional capacity of that patient using a myoelectric, if they choose to use a myoelectric hand or prosthetic device. And so we'll see things like body power hooks or hands, myoelectric prostheses, or you can even get some hybrid form of these. Rehab focus, again, is going to always be elbow range of motion, specifically looking at pronation and supination, myoelectric site training, desensitization, terminal device training, ADL, and vocational reintegration. This is where it'll be very important to have that occupational therapist a part of the rehab team here. Then we're going to move on to the elbow disarticulation. So we're going to move the radius and also the ulna, and the amputation for the elbow disarticulation removes the forearm at the humeroradial ulnar joint while preserving the entire humerus, including the epicondyles. And we can just kind of make a view rotation here so you guys can see the entire structure there. Like the knee disarticulation in the lower extremity, elbow disarticulation preserves functional anatomy at the expense of prosthetic cosmesis. The epicondyles create a natural self-suspending fit for a prosthetic socket. The prosthetic system can lock itself on, and this is mechanically elegant. The trade-off, however, prosthetic elbow mechanisms must now fit into a space that the epicondyles have narrowed. Standard elbow joints sit proud of the limb at this level, creating asymmetry with the contralateral side. The prosthetic elbow appears to be at a lower position than the side elbow. Functionally, all humeral rotation and shoulder biomechanics are entirely preserved. Every degree of shoulder motion, flexion, extension, abduction, internal and external rotation translate directly into prosthetic positioning. The patient is not compensating with trunk motion to reach across midline. So again, with the upper extremity, we want to make sure that we're maintaining the internal and external rotation, maintaining the joint at the shoulder, also restoring scapular mechanics. And I think we also have to start looking at the mechanics at the clavicle as well, and also restoring motion at the thoracic spine to ultimately take off some of the stresses that will be caused of overuse of the opposite side extremity. So again, you'll see specialized elbow disarticulation, prosthetic elbows, body powered or myoelectric terminal devices. Our rehab focus is going to be full shoulder range of motion, strength, prosthetic elbow locking mechanism training, and terminal device trainings as well. Moving along, we can go from the elbow disarticulation moving above the humeroradial ulnar joint, and then we have our transhumeral amputation. Now, this is the amputation through the humerus above the elbow. The residual limb retains some humerus, and the shoulder joint and all shoulder musculature is preserved. The key surgical detail for rehabilitation clinicians is that transhumeral amputations are typically made approximately 4 centimeters proximal to the elbow joint. Why is that? That's to allow the prosthetic elbow locking mechanism to sit at the same anatomical position as the contralateral elbow. This creates cosmetic symmetry and appropriate prosthetic mechanics. There is a functional cliff at this level. Any transhumeral amputation at or proximal to the pectoralis major insertions, roughly about an upper third of the humerus, begins to function like a shoulder disarticulation, because now humeral rotation becomes impossible or minimal. The residual humerus no longer rotates in a mechanically useful way. So I'm going to pull up here, and we can see if we fade the others, we can see where this pectoralis major inserts. And as you can see here, if we look at the fibers of the pectoralis major and from the sternoclavicular and the sternal head and the clavicular head, you can see that these muscle fibers actually flip over one another, which helps cause some rotation. And when we lose this ability here, we start to lose that ability to rotate, right? Because again, we will have some rotation because we still have the fibers of the rotator cuff, but we lose a large part of the lever arm that causes, or at least facilitates or helps with internal and external rotation. If this level is unavoidable, the surgeon must weigh whether preserving the very short humeral segment is worth the surgical complexity versus proceeding with a shoulder disarticulation with a cleaner course. Internal and external rotation of the residual humerus is a prosthetic control mechanism. It allows the user to orient the terminal device without elevating their shoulder. If it is lost, your patient is shrugging their shoulder to position their hand. And you will see this, and it will not be subtle. Myoelectric control at the transhumeral level requires more sophisticated signal acquisition. Two sites, typically the biceps and the triceps, control elbow flexion and extension. Sequential or co-contraction patterns to access the wrist and hand. More degrees of freedom in the prosthesis means more control complexity and more training time. So we'll see things like endoskeletal body power or myoelectric arm with the prosthetic elbow, multi-articulating hands with require sophisticated EMG control. So our rehab focus will be shoulder range of motion and strength, especially in internal and external rotation, extension, abduction, myoelectric site training, elbow control, and terminal device training. And we'll talk about that in more detail when we are in person. And lastly, we'll talk about the shoulder disarticulation and the forequarter amputation as well. The shoulder disarticulation removes the entire upper extremity at the glenohumeral joint, the clavicle, scapula, and all the scapular musculature, trapezius, rhomboids, serratus, anterior, levator scapula, they're entirely preserved. What this means for rehabilitation is scapular motion becomes the primary prosthetic control mechanism. The prosthetic socket typically captures the clavicle and scapula, and the scapular protraction and retraction generated by the serratus and rhomboids drives the cable and harness system of body powered devices or triggers the switch and EMG systems of myoelectric arms. Scapular mobility at this level is not optional. It is the prosthetic prerequisite. Full pain-free scapular protraction and retraction, elevation and depression, this is what your patient needs before they can effectively control any prosthetic device. If scapular dyskinesis is present, if the patient has restricted thoracic mobility or a frozen shoulder type position, prosthetic function will be severely limited. Cosmetically, the shoulder disarticulation preserves the shoulder contour because the clavicle and the scapula remain. This is a functional and cosmetic advantage over forequarter amputation. The rehabilitation goal at the shoulder disarticulation begins with the shoulder girdle, not the prosthesis. We have to optimize scapular mobility and strength before fitting. A prosthesis mounted on a rigid, poorly mobile shoulder complex is essentially just dead weight. We'll see shoulder cap sockets, body power system with cable harness driven by scapular protraction or myoelectric system using the residual limb muscle sites, chest expansion or scapular motion contraction of the surrounding musculature. Our focus for rehab, we want to make sure we're looking at scapular mobilizations, thoracic mobility, chest expansion training, myoelectric site identification and training, ADL adaptation, and also pain management. Moving through to the forequarter or the interscapular thoracic amputation. This is the most proximal upper extremity amputation. It removes the entire upper extremity along with the clavicle and scapula, and what remains is the chest wall alone. This procedure is almost exclusively performed for malignancy, soft tissue, or bone sarcomas of the shoulder girdle that cannot be treated with limb salvage, or for massive trauma or uncontrolled infection. It is rare, and the functional demands it creates are extraordinary. There are no residual muscles with distal attachments remaining that can directly control a prosthesis. Control must come from whatever musculature survives on the chest wall, like the pectoralis major, the latissimus dorsi, and even contralateral shoulder motion. Chest expansion becomes a primary control input. Prosthetic fitting at this level is technically challenging. The socket must interface with the chest wall and create a shoulder contour. Many forequarter amputees elect to use a passive cosmetic shoulder cap rather than a functional prosthesis because the control complexity of a functional system is difficult to master, and the energy expenditure is pretty high. Four-quarter amputees frequently pursue upper extremity independence through one-handed techniques rather than prosthetic use. And again, this is just like with a hip dysarticulate. This is not a failure. This is a pragmatic adaptation. Your role is to optimize what the patient can do with what they have. So body image, prosthetic decision making, psychological adjustment are central to four-quarter rehabilitation. The shoulder silhouette changes dramatically and visibly. These conversations belong in the rehabilitation space from day one. Again, you'll see those passive cosmetic shoulder caps, endoskeletal body power systems. These are really high demand users. Myoelectrics are rare, and it's a complex control interface. As far as our rehab focus, we want to really highlight the one-handed ADL training, contralateral upper extremity strength, trying to maintain and preserve the function of the contralateral side as much as possible, and scapular and trunk conditioning, chest expansion, also looking in all levels of amputation, looking at psychological support and vocational rehabilitation.